Thank you. Welcome everybody to today's Primary Care Commissioning Committee meeting held in public. Do we have any apologies for absence?
Yes, we do. We have apologies from Oliver Wood and Lynn Wilson as members, and Michelle Stamp from the local authority.
Thank you. Are any members of the public wanting to join?
No.
Thank you very much. I'll confirm that we are quorate. Are there any declarations of interest outside those on our register? Okay, thank you. Item 4 of the draft minutes of the previous meeting. Does anybody have any observations for accuracy? On the committee, happy to accept those as a true record of the meeting. Yep, thank you. On the actions log, we have an action to look at the risk of home working and to discuss the health and safety actions around there. I haven't had the opportunity to discuss those with Neil, and I'll have to roll that action on to the next meeting in March. So apologies for that. If you could amend the due date, please. Sue?
Yeah.
Takes us to item 6, presentation from Claire and Bob.
Yeah, if it's okay, I'll just give a brief overview on the background and then I'll hand over to Bob. So pressures within primary care become increasingly evident, and as such it's important that there's a mechanism for reporting and comparing activity between practices and over time to demonstrate increasing workloads. A dashboard was first developed following discussions back in January 2020 between the CCG Chief Officer and Medical Director and myself to enable us to understand these pressures and help us to plan accordingly. More recently, we've consulted with primary care colleagues through the Primary Care Bulletin, SurveyMonkey and drop-in sessions as to what they would like to see, what practices would like to see within the reporting tool, and subsequently developed this dashboard, which we're going to demonstrate, which allows for presentation of primary care appointment data as well as wider system data from the urgent and emergency care network, for example, A&E, both at practice and PCN level. In terms of distribution, an unanonymised version of this dashboard is updated and shared with the CCG senior team, and we have more recently gone out to practices with an anonymised version, which we're going to demonstrate today. I'm hoping that in time practices will feel comfortable to share their data with their peers, as it is actually intended as a benchmarking report. I'll just hand over to Bob, who was instrumental in developing this dashboard with us. He'll guide you through the report and articulate some of the data quality issues and concerns which we're working through to understand and try and improve on. Thanks, Bob.
Okay, so I'll put the report up on screen in just a moment. Just to say ahead of that, what the report includes are data on seven different points of delivery. So we're looking at what happens in primary care, but then what happens, where else do those patients go at a practice level, what other access points do they make. So we're looking at time to go through all 7 tabs in any detail. What I would point out, and it links back to what Claire just said about data quality, there's a number of tabs which are driven by national data flows and a number of tabs which are driven by local data flows. And there's an important difference between the two. When you talk about national data, you're usually talking about national standard and to some extent a like-for-like comparison of the data. Whenever you look at the local data flow, then you have the potential for variation in reporting and recording by provider. Okay. We'll point out where that's the case. I think on some of the tabs, I think it's quite obvious that there's something different going on in different localities or different providers. And something not be. But we need to bear that in mind, the benchmarking, something different on some of the tabs. So share my screen and show you this report. Okay. So hopefully you can see that now.
Thanks, Bob. So
the format and the functionality on each of the tabs is the same. So we'll spend a little bit of time on this one and then we can flick through the other tabs quite quickly. You're looking at GP appointments, so appointments in GP practice. This is the anonymised version. So every PCN is allocated a letter. I don't know who's who. You can guess some of them, so it might be anonymised. It's not fully anonymised because some people, some practices, some PCNs are guessable because where they sit in the benchmark. GP practices are also anonymised. So each practice, each primary care network will know their own code in effect. What you have on each of the tabs, you have a number of selections. So this bit at the top here, you can select to look at either Gateshead or Newcastle. You can select whichever time period you're interested in, or you can select one or more practices or one or more primary care networks. There's always, whenever we're doing comparisons, we're looking at rates. So it's rates per head of population. So the different sizes of the practices is taken into account. And on each tab, you will have a table on the left-hand side, which will go from highest rate of access to lowest rate of access. And again, here the practice and the PCN are indicated, but they're coded. You have the actual number of appointments in this case, and then the rate per 1,000 patients. And they are just ranked from highest to lowest. The colours are a heat map. I think there was some discussion about whether we should change the colours of those, because there's no indication of what's good and what's bad here. It's just what's highest and what's lowest. So maybe reds and greens have a different connotation, but that's where they are at the minute. So a primary care network benchmark will appear on each tab, and that's static. That doesn't change. But then you will have a practice benchmark in each of the networks that are colour coded, and then a trend. So the trend relates to whatever selection you've made. So if we select a primary care network, I don't know who primary care network E is, so maybe one of the ones I could guess, may not be, but if that's my network, I want to go in and see what's going on for me. Then once I've selected network E, then the practices will be highlighted on the table, so I can see where my practices are. The benchmark now is a benchmark of those practices within that primary care network. So you can look at, again, these are coded, so if you're sitting within a practice, you know who you are. You have the ability, if you wish to do this within a primary care network, is to share information on, okay, who are the other practices, and then you can start to work together and have some discussions about what is going on within that network. Are these is the variation here true, or is it to do with recording? I said at the start that there's the potential for differences in recording between providers. Every GP practice is a provider. These what have we got here? 7 practices within that network. There's no guarantee that they are all recording their appointments in the same way, that they're all recording the same appointments, that they're all flowing data for the same staff groups. But you can have those discussions within a network level if that's what you choose to do. The trend here in this case is for that primary care network E, which I chose. If I didn't want to look at that, but I'm sitting in my own practice and I just want to look at my trend, and I happen to know that I'm practice 28, then the trend now is for my practice. So that's kind of the standard functionality that is on every tab. GP appointments is a local flow of data that we're using here. So there is that potential for some variation in recording. And I know there is some work going on to try and understand that and trying to standardize that as much as you can. It's never going to be 100% when you have different providers working to a non-standard flow. What I'll do now, I'll speed up a bit and I'll flick through the 3 tabs that are based on national standards. So here I think the benchmark is more secure. So A&E attendances, so we have exactly the same layout and exactly the same functionality. There's more you can do with this, and I think one of the things that I'd be keen to do is think about what else we can do with this to make it more useful. In terms of A&E, there's more that we know. We know how patients arrive. who's a walk-in, who's an ambulance delivery. We know what happens to them, who's admitted, who goes away, who's sent back to GP practice, who's sent wherever. We know what time of day they attend, so we could split this in hours, out of hours. So there's more selections that can be made here. We do know, I say you're on safer ground in terms of benchmark here, but we don't know some of the things that drive attendance at A&E. And one of the A&Es, we can split this out into main A&E departments, MIU walk-in centres as well, so we can separate the two out. But how close your practice is to the department matters. We know that the major driver of A&E attendance is a level of deprivation that a practice serves. So again, there's other things that could be built in here to make that tab more useful. 111 calls. I say it's a national flow. It's a national specification for 111 and 999. But the big advantage we've got with this data here is it comes from a single provider. So again, you can have some comfort and you can look at the benchmark with some confidence because the data is coming from one source. So therefore, they would be working to one standard. You have the same kinds of selections, exactly the same format. Again, in out of hours here might be useful. Actually, patient outcome. Actually, what's the disposition of these calls? Other differences, other kinds of things that could be built in here. One kind of warning that I always give people when you're looking at 111 data is actually what you look at here are calls answered rather than calls made. So sometimes, oops, yeah, just resize that again. Sometimes you see a trend like this, a decreasing number of 111 calls, which is not what we would think is going on in the system at the minute, but it's calls answered. So if you have a higher rate of abandoning calls, which for a period of time, the back end of last year we did have with NEAS, you can get this trend. It doesn't mean there's fewer people making a call, it means there's fewer calls being answered. I will now speed up quite a bit. 999, same again, we could look in out of hours. We can look at outcomes of those 999 calls. And then I'm going to look at the three other tabs where the data was run on local flows. And I think on these three tabs, certainly on two of them, you can see quite a difference in terms of recording, I think. Extended access. If we look at the difference in the rate between Gateshead and Newcastle, I'm not an expert on how much extended access capacity there is in Gateshead and Newcastle. That difference looks too big to believe to me. And if you look at the benchmark, the orange bars there are Newcastle PCNs and the blues are Gateshead. I think we've got a difference in the way that the data is being captured there or the data is being recorded. Would be my suspicion. And GP out of hours, we have a similar pattern here. I don't believe that there's 10 times as much GP out of hours capacity in the system in Newcastle when compared to Gateshead. And the final tab, this actually should be more like for like. Ignore that rubbish title at the top, which I only just noticed just before I came on. That's wrong. That should say Think Pharmacy first. That's been copied from the previous tab and not corrected. But Think Pharmacy first in terms of the access rates into there. It's the other thing, the other tab on there. So that was a very quick rattle through. I'm going to unshare my screen and see if anybody's got any questions on that. I think my starting point would be, I think there's a lot more could be done on the report. There's lots of other things could be built in. I think I'd love to build in on names of practices because I think that's what makes it into something more useful than it currently is, because your best comparator is how am I doing compared to the guys next door or a similar practice in another part of the city. Can't quite do that at the minute, but there's other things that could be built in. But I'm also really keen as well, a bit of caution around some of the benchmarks where you're looking at local flows of data, and there's clear differences in recording in data capture. Shut up there and take any questions. Dominic, I think you were first.
So just to thank Claire and Bob again for bringing this data together, because this is the first time we've had primary care activity data, and we've had years of secondary care data. And I think it balances the conversation really, because I'm still learning how to sort of navigate the spreadsheet and get it to tell me what I want it to tell me. But one of the big things it tells me is that every month we are offering approximately 80,000 appointments in general practice across Newcastle and Gateshead, and to have that high level figure to compare with A&E attendances and hip replacements and emergency admissions is actually a very powerful consideration to think about the healthcare offer that we have overall in the two places. So just huge gratitude, and I'm sure it will become more and more useful as we improve the quality of the data, but also learn to sort of navigate the tabs and help ourselves to understand what it's saying.
Georgina?
Yeah, I'm going to echo Dominic again. Absolutely, it strikes me at the large volumes of activity that are happening in primary care, and it's actually great to have some way of being able to demonstrate that to the system. I think it's also useful on a practice and a PCN level. We've had some conversations in my practice around it. I think possibly trends are more useful at the moment because you can compare yourself to yourself. It's harder to compare between practices until we've got a bit more standardisation. But I think it has plenty of opportunities for us to try to understand a bit better about how our patients might be accessing the system, and how changes that we instigate in the practice might then have an impact on that. So yeah, I think it's been really helpful, and particularly in a system level of helping to genuinely for the first time understand the true volume of activity that's happening. Thank you.
Thanks.
Bill?
As you say, Bob, the data needs to be as clean as possible, and having an order of magnitude difference between two measurements tells you that there's a problem with the data. And were these data to get into the hands of the tabloids in this raw fashion, they'd be jumping up and down and drawing conclusions. So it's in everybody's interest to make sure the data are as clean as possible, and as time goes by and people's confidence gets better, it'll get more and more refined until it becomes actually a very useful tool. I mean, it's pretty good to begin with, and hats off for the work you've done. But I think a lot of the improvement now will come with the primary care clinicians themselves.
Yeah, Bob, the data has numerous uses, not just, as Georgina says, comparing trends in your own practice and your own practice performance, comparing the PCN, practices within the PCN and that kind of stuff, but also from a commissioner's point of view. If we'd have had that data 5 years ago, we may have made different commissioning decisions. I can think of decisions that have come to this committee in the last 5 years where having some data like that would have made a significant difference in evidencing our decision making, particularly when we've looked at mergers, closures, closing of lists, and those kind of real decisions that really impact patients. So looking at some of that data to inform the committee's decision making is a huge step forward. Is there any plan to add any finance data to that, so that we can compare return on investment, spend per appointments, and real those kind of things? Because some of our practices cost more to operate than others, and have different list sizes for that.
At the moment, no. the only things that come with well, I was going to say the only things that come with an agreed tariff attached. I'm not sure if that's true or not. I was going to say ANA 111999. Concept of the tariff on a GP appointment. That's not something that I've been involved in the discussion with. At the minute, I know that a GP appointment is not a standard thing. It's not a standard length in each practice.
Yeah.
So it'll be quite hard to do. Mm-hmm. The kind of ratio between practice income and list size. I guess you could do it. I don't know. It's not the kind of conversation I've been involved with in the past. So I don't know what the GP on the call think about that.
It may be because people don't want that conversation.
Okay.
But I think it would give commissioners another set of data to make commissioning decisions by. It would also give practices another measure to measure themselves by in terms of their efficiencies and that kind of stuff, and also to support the requests that they may make for additional support, additional resources, increasing estate size, all those kind of things. So I'm not sure if that's something that that Dominic might want to have a conversation with the team about developing or not. Bill.
Jeff, I would just urge a bit of caution here, because the worry is once you start getting into that level of granularity, unless you're comparing like with like, you open up a really, really bad discussion. And when you add or figure deprivation into this, those practices who've got a lot of deprivation, you can't really compare Gosforth practice with St Anthony's unless you've got very, very clean data.
Yeah, no, I don't disagree with you at all. And we should aspire to have the best data possible. But we all recognise there are two different business models within primary care, don't we? The social care model and the private sector model. So it'd be interesting to see which in different measures of value returns the best value. And there are lots of different measures of value, as we know. But great piece of work, Bob. Thank you for presenting it. It's a big step forward, and thank you to the team for doing that. Does anybody else want to add anything? Okay, thank you very much. We're on to items. Claire, is that you? Is that anything else you wanted to add?
Is it not pancakes at Claire's house now?
It is now, yes. They've been desperately patient. No, nothing else for me. I think just to note that the next steps, as said, this has just gone out to the practices, the anonymised version, and just encouraging the practices to get to understand their own data and start sharing it with their peers. And then hopefully we can work to improve the data quality, as Bob's mentioned.
Yeah.
Thank you.
Very much. Enjoy your pancakes.
Will do. Thank you. See you.
So item 7, I'm not sure who's presenting item 7.
That's going to be me, Jeff. I'm picking that up on behalf of Kirsty because she was unable to attend.
Yep.
Go ahead.
Yeah, please do.
Yeah. Okay, so Kirsty put this paper together on the back of 3 practices who had been rated as good previously by the CQC and have had recent inspections and are now requires improvement. So the 3 practices, and I'll just go through a summary of each after the brief summary. The practices are Park Medical Group in Newcastle, Parkway Medical Group in Newcastle, and IJ Healthcare in Gateshead. Kirsty's put a bit in her report about the CQC inspection methodology, just to actually say that the CQC asks the same 5 questions of all services, and that's around whether they're safe, effective, caring, responsive to people's needs, and are they well led. So that's the same questions that they ask, and they give 4 possible ratings CQC, which range from outstanding to good to requires improvement to inadequate. So if I just summarise for Park Medical, that's actually based at Fordham with a branch surgery at Kingston Park, and they've got a patient population of approximately 13,000. The CQC inspected at the end of November 2021, and the report was published on the CQC website in January 2022. Now, with the overall rating of requires improvement, it doesn't mean that all elements requires improvement. So I think she's noted there that the 3 areas that actually came out as requires improvement were safe, effective and well led, with caring and responsive being good. The key inspection findings, which I'll just briefly summarise, it was around the appropriate and safe use of medicines, including medicines optimisation, and that wasn't always effective. It was around patients' needs not always being assessed and care and treatment not always delivered in line with legislation. The practice was unable to fully demonstrate that staff had the skills, knowledge and experience to carry out their roles, and the practice did not always have a clear and effective process for managing risks. There was a few points on there added that were sort of more positive around, staff dealt with patients with kindness and respect. They had adjusted how it delivered throughout the pandemic, and the practice did have some clear systems, practices and processes to keep people safe and around safeguarding. So the CQC actually found 2 breaches of regulation. So what they actually do is they ask for a CQC action plan to be put in place, and CQC will subsequently go in and re-inspect the practice. So that's the first one, which was part medical. I don't know if anyone wanted to comment or had any questions on that before I move on to the next practice. Shall I move on? Move on. Okay, so Parkway Medical Group, that's located Chapel House in Newcastle, patient population of around 8,645 patients. They were inspected in early December 2021, and the report was published on the CQC website 26th of Jan 2022. With this particular practice, there were 4 areas that came out as requiring improvement, and that was safe, effective, responsive and well led. Caring did come out as good on this particular inspection. The key findings for this practice was that there was a significant shortage in staff, which included GPs, and that impacted on their ability to provide safe care. There was evidence that some issues affecting patients had not been actioned following safety alerts. They did say in the whole patients mainly received effective care and treatment, although there was a significant backlog of patients waiting for review, and there wasn't particularly an action plan in place to address this. There had been a number of complaints with this particular practice, and staff morale seemed to be quite low as part of the inspection. The practice had adjusted how it delivered through COVID, but patients struggled to access care in a timely way. So with this practice, there was 1 breach of CQC regulation, and again, an improvement plan will be requested, and a follow-up will take place through CQC. Shall I move on to the final one and then sort of summarise? Jackie, did you want to come in?
Sorry, it was just to make comment really that these 2 practices, as far as I'm aware, haven't been poorly performing practices historically, and I guess it was to understand how many practices were assessed by CQC over this time period, and out of that, how many would have been in the same position. So in essence, how much is it a long term and how much is it a short term deficit really?
And that's a fair comment, and I think one of the things we've discussed is that actually the way that they've done the inspections has actually changed as a result of COVID. So they're being done more remotely, they're being based on data, and they're possibly looking at things that they hadn't looked at previous, which might explain the change between good and requires improvement. So I think sort of when I come on to the end of this, I'll do the Gateshead one, but there are things we're sort of doing as a CCG to be supportive towards those practices and to actually look at the issues that have been raised.
Great, thank you.
Georgina, then Dominic, please.
Yeah, I agree, Jackie. I think that particularly the Parkway one that you've just discussed, it sounds like they were in the middle of a crisis at the beginning of December, and actually if they'd gone into most practices in the North East at that point, they would have maybe found all those issues too. So I think if you were at that practice, that might just further reduce your morale rather than actually motivate the team to improve. So it's a little bit disappointing, I think, from CQC to kind of pick their timing, but then also comment on stuff which isn't practice specific. It was really a massive issue across the whole patch at that point. Not to comment on some of the other things that they picked up, but particularly that being no staff shortage, people self-isolating, well, everywhere was in that position in December. Yeah.
Thank you. Dominic?
Yeah, so I think Rosie's point that CQC are now using a very different inspection regime has led me to speculate that actually many practices might be in a requires improvement scenario if they were all subject to the new inspection process. Of course, they're not going to be, but they have indicated that if there's been either new premises or a significant change of registered individuals, that they are likely to get inspections. So we have been giving this message to practices. We've been highlighting the sort of support and preparation that they might be doing. And in terms of the practices that have got requires improvement, we have written out to them to sort of, you know, in an understanding way, say, look, we know you're going to be in a process. We know you'll be disappointed with this. We know you'll have some public scrutiny from elected members or the press. We want to help you and help you understand this. I think the important thing to note is that CQC are now using many more GP clinical inspectors who can remotely interrogate the clinical system. And so a lot of the themes that are coming up are things like prescribing of things that dangerously interact, that looks like it's got through the safety net. So they are very much scrutinising detail, particularly around medicines. We can't argue that it isn't the right thing to do. It is, but it does mean that there are going to be practices that are getting inspection results that they haven't anticipated because they haven't got those safety nets in place that are absolutely fail-safe.
Thank you. Ross, do you want to go on to the last one?
Yeah, for the Gateshead one. So it's IJ Healthcare, Hollyhurst Medical Centre is based in Wenleighton, and there's also a branch at Elveston Road in Ryton that has a practice list size of just over 4,500. It was inspected at the end of September 2021, and the report was published on the 10th of November. Again, there was 3 areas where they came out as requires improvement, which was under safe, effective and well led, with caring and responsive being good. The practice had been inspected, I think, previously in August 2018, and they were previously good. The key inspection findings, they were saying that there have been some improvements within the practice because there has been a number of inspections previously at this particular practice, but there was again some issues around patients' medication, which we've discussed with the others. The practice didn't have a sustainable and stable clinical team, again low morale, which I think leads to the conversations we've had. There were some issues around recruitment records and arrangements for infection control. There's some things around minor surgery hadn't always been correctly documented, so there's things around sort of record keeping and things around those areas. And again, there was links to sort of sustainable and stable clinical teams under the well-led area. So again, there were 2 breaches of regulation through the CQC, and the practice is advised to make improvements. And there's going to be 3 monthly meetings. It says here with health visitor. I don't know particularly why that was specified. But again, CQC action plan, follow-up inspection. And then I'll just go on to the next steps. Actually, before I do that, I think Bill's got his hand up.
Yeah, just to say, the important thing about this is that the message should get out that none of these practices have failed on the caring. And I think that's really important, because once an institution starts to fail on that, then you've got problems. And the second thing is all 3 have had issues with well-led. And when I do the inspections of CQC, I just go in and look at the executive teams in hospitals, and well-led is a key element to that. And this is one thing where we might be expected to give some support in training and helping at senior levels. Maybe the PCNs could have this discussion. I don't know, but that's something that very often people don't realise, that they're not good leaders. So it's a really key element that we as commissioners and senior people in primary care can help with.
Okay, so I'll just finish off with the next steps on this report. Yep. So obviously all 3 reports were discussed at the primary care quality meeting that we had recently on the 17th of Feb. I think, as Dominic has alluded to, we are going to sort of set up some supportive discussions with them. we've discussed about the common themes as well, the fact that there's things around medication and around safety alerts. There's a lot about sort of prescribing. So what this report says is that the themes are going to be shared within, they have been shared with the CCG GP prescribing lead to actually review and action that as appropriate, so to take forward some of those medication issues. We also agreed just to raise awareness of the CQC inspections, the fact that obviously across Newcastle and Gateshead we'll share in the bulletin that the inspections are recommencing following perhaps a pause, and sort of what some of the findings have been, just to almost give sort of practices the heads up and to look at their own systems and to see, you know, potentially what they need to be concentrating on before CQC could potentially come in and inspect. I think that's as much as I had to say on that. If there's any other comments.
Just one which is really addressed to Dominic. Given that primary care pressures and primary care performances on the CCG's risk register, is that something that we should review our mitigating controls, given what appears to be a bit of a theme about the new inspection framework?
Yes, I think we should. So maybe we'll take that as an action for me and Ros and Sue. And
to see what support, what support you and the team can give in order to prepare others for the new or for the next inspection, if that is appropriate or not.
Yeah, and we are doing that, but I think it's right to capture that mitigation on the risk register as well. So Ros and Sue and I will talk to Neil Hawkins about how we sort of capture.
Thank you. Does anybody else have any other observations? Thank you, Ros. An interesting report in many ways, and considering the significant pressure that primary care has been under for the last 12 months plus, I think it's good to see the impact of it from an independent inspector, and rather than just the anecdotal evidence that we hear from individual practices. It's good to see actually that is the validation of that, and the validation of the impact of the workload and the crises and policy and the policy decisions that have been made. So yeah, thank you very much. Does anybody have any items of any other business? Our next meeting is on the 29th of March. I know it's at a slightly earlier time of 5 p.m. Than today's meeting. So if there's no any other business, I'd like to thank everyone for their attendance and look forward to seeing you at the end of the month.